Hello, my dear. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The title of my lecture today about puberty. So, what we wanted to know about puberty, the definitions, physiology of puberty, hormonal changes, somatic, genital, and psychological changes, management of puberty, precocious puberty, and lastly, the delayed puberty. As you see, we will talk about the normal physiologic puberty and the abnormal one. Let's start our journey with the definition. Puberty is a developmental stage characterized by physical and psychosocial maturation. It is a period of life, 4 to 5 years, during which secondary sexual developments occur. The sex organs mature, menstruation commences, and reproductive capacity is attained. So there is maturation of the hypothalamo-pituitary gonadal axis. Let us see the physiology of the puberty. Please look to this picture. This is the hypothalamus. Hypothalamus become activated during puberty and release gonadotrophic releasing hormone. Gonadotrophic releasing hormone stimulate the anterior pituitary to produce FSH and LH hormone. FSH and LH hormone act on the ovary, causing stimulation of the follicles to grow and produce estrogen. And this estrogen produced through these follicles will stimulate the growth of the uterus, will stimulate the secondary and cause the secondary sex characters, also help in the development of the genital organs. So, what is the cause of this stimulation of the hypothalamus? There is many theories tries to explain that. One of them is that the negative feedback mechanism by very small amount of estradiol in the circulation of the childhood girl become released. Second, leptin produced from the fat cells stimulate the hypothalamus to produce gonadotrophic releasing hormone. So the idea is stimulation of the hypothalamus and activation of the hypothalamo-pituitary ovarian axis. Also, release of the inhibitory intrinsic CNS factors. These inhibitory factors released so that the hypothalamus becomes free and they release gonadotrophic releasing hormone. What about the hormonal and physical changes? Gonadarch means release of gonadotrophic hormone in pulsatile manner. This release of gonadotrophic hormone stimulates the anterior pituitary to produce FSH and LH, which stimulate the ovary to help in the growing follicles. So, gonadar means release of gonadotrophic releasing hormone and its effect. Adrenarche is the production of androgen by the adrenal gland, which will lead to formation of pubic and axillary hair. The physical changes described during puberty using sexual maturity ratings, such as Tanner stages. What about Tanner stages? It is 5 stages, as you see here, starting from early stage 1, nearly simulating the childhood age, up to stage 5, which is maturity of puberty stage. So, what about the pre-pubertal or stage 1, the breast development is prepubertal. There is no pubic hair and no other pubertal event. In stage 2, there is subareolar breast buds. What about the pubic hair? It is sparse, long, slightly pigmented, straight, along the medial labia. The pubertal event here is peak height velocity. So there is linear growth. Stage 3, there is breasts and the areola are further enlarged with continuous rounded contour. The pubic hair becomes darker, coarser, more curled, spread sparsely over the mons pubes. What about the pubertal event? Also peak height velocity. So stage 2 and 3, both of them there is linear growth in a peak height velocity. Stage 4, more growth of the breast, areola and the nipple form a secondary mound above the contour of the breast. What about the pubic hair? Become adult type, covering the pubic area and labia majora, but not extending to the inner side of the thigh. What about the pubertal event? Menarche start. Stage 5, more growth of the breast becomes mature adult stage, nipple projection without secondary moon. What is the pubic hair? It is now adult type, covering the pubic area and the inner side of the thigh. The pubertal event here also is menarche. Let us look to the picture. This is the tunnel stage by the picture. This is starting from stage 1 here as regard the breast, and here as regard the pubic hair. As you see here, there is no growth of the breast in stage 1 and there is no pubic hair yet. Okay, starting of the breast bud from the second stage and pubic hair start at the labia majora. Increase in the amount of the pubic hair here as you see, and it becomes more pigmented and more dark and more coarse, and reaching also the inner side of the thigh. Here also the breasts start to grow, reaching the adult breast here in stage 5. The linear growth, mainly the peak in the stage 2 and 3. Okay, what about stages of pubertal development? Telarch means prominent nipple, occur at the age of 9.8 years. Adrenarch, appearance of pubic hair, occur at the age of 10.5. Beginning of roundness of the body contour by selective deposition of fat after the age of 12. Premenarchal growth spurt during the year preceding menarche under the effect of growth hormone and insulin growth factor, and it passes through 3 phases. Minimum growth velocity here, the linear growth 5 centimeter per year from 4 years of age to puberty. Then we reach the peak high velocity, which in the Tanner stage, if you remember, stage 2 and 3, 8.3 centimeter per year during the age 11 to 12 years. Then a stage of decreased velocity, the girls complete linear growth at 15 years, and it is different than in what happened in boys. In boys, it reached up to 17 years. Menarche at the age 12.5 in average years, and this is the first menstruation in life. Anatomical maturation of the genital tract happen, also behavioral changes and psychic maturation. Let us summarize the changes occurring at puberty into three big categories: somatic changes, genital changes, and psychological changes. Somatic changes include growth of the breast, female configuration with fat deposition on the pelvic girdle, in the buttock and the breast, appearance of pubic and axillary hair, closure of the epiphysis in late puberty. What about the genital changes? Growth of the labia majora and decrease in size of the labia minora. Second, vaginal mucosa with deposition of glycogen in the vaginal epithelium and the vaginal pH become acidic. Increase in size of uterine body. The fallopian tubes become thicker, longer, with development of cilia and peristalsis, and menstruation occur around the age of 12.5. Psychological changes include imagination, sexual desire, shyness of girls. This is the changes that occur during puberty. What is the role of management of puberty? Mainly it is done by the parents in school. First, knowledge about reproductive health. The girl should know about this phase in life. Psychological preparation to the girl, and we should tell her about menstruation so she will not be surprised when it occurs, and it's very important. And also it's important to tell her that she can do her daily activity during menstruation, no problem with that, except for some religious factors or items which cannot be done during menstruation, like praying. Reassurance about symptoms of puberty. Also, we should tell the girl and her family about the menstrual irregularities which may happen early during puberty in the first few cycles, and mostly they are anovulatory. Also, attention to physical activity and enhance the physical exercise and enhance her to take adequate and balanced food in this phase in life. Let us go to the abnormal puberty. Abnormal puberty include two main groups: precocious puberty and delayed puberty. Precocious puberty means pubertal development beginning before the age of 8 years. The girl will develop secondary sex character early, before the age of 8 years. This is the cutoff. But in delayed puberty, there is failure to develop secondary sex character till the age of 13 years. And no menarche till the age of 15, which is called the primary amenorrhea. Let's start with the precocious puberty. As you see in this picture, this is the secondary sex character with development of the breast bud, and fat deposition before the age of 8 years. So, the definition of precocious puberty is development of secondary sex character or development of the breast before the age of 8 years. The classification includes central one, peripheral one, and the combined. According to what? According, is it gonadotropin dependent or not? Central, it is gonadotropin dependent and it's called the true one. And it is also isosexual, I means it is feminizing one. Peripheral, gonadotropin independent one, and also it is called the pseudopuberty. The peripheral one may be isosexual or heterosexual. Isosexual, feminizing one, or heterosexual, virilizing one. Or combined. In combined one, it started as a peripheral, precocious puberty, later on induced maturation of hypothalamo-pituitary gonadal axis and triggered the onset of central puberty, like an example of McCone-Albright syndrome. Okay, what about the etiology? The etiology will depend on our classification into central and peripheral. In central one, there is early maturity of the hypothalamo-pituitary gonadal axis. This early maturation produces gonadotrophic releasing hormone, which stimulate the pituitary to produce FSH and LH and act on the ovary to stimulate the growing follicles. What are the causes of the central one? Maybe idiopathic, this is the commonest one, 90% of cases, or maybe it is due to brain lesions, trauma, infection, tumors, irradiation, or hypothyroidism, or maybe familial causes. What about the peripheral one? The peripheral one may be isosexual or heterosexual, as we said before. This is feminizing one, and this is masculinizing one. Why it is feminizing? Because it depends on estrogen. And heterosexual, why it is masculinizing? Because it depends on excess androgen. What are the causes in peripheral isosexual? Including feminizing ovarian tumor like granulosa cell tumor of the ovary, or estrogen intake exogenous, or due to McCone-Albright syndrome. What about heterosexual one? It is masculizing due to excess androgen, as in cases of congenital adrenal hyperplasia, adrenal gland tumors, virilizing ovarian tumor like Sartor-Leydig cell tumors. So what about the diagnosis? The diagnosis include the medical history, the physical examination, and the investigation. In medical history, I wanted to know the age at onset, when it developed, the symptoms and size of puberty, pubertal progression, any history of CNS trauma or infection, or any history of headache, visual disturbance, or seizures, any symptoms suggesting hypothyroidism like fatigue, sleepiness, increased sensitivity to cold, constipation, exposure to exogenous sex steroids, the patient received drugs containing sex steroids. Family history should include pubertal timing, especially the mother's age of menarche, and sister also. What about physical examination? Measurement of the height and weight and body mass index. Do Tanner staging, as we said, we have 5 stages. We should know which stage the patient in. Some signs of McCone-Albright syndrome, like cafe au lait macules or patches, as you see here in the picture. This is the patches of McCone-Albright syndrome. Signs of hypothyroidism and enlarged thyroid gland, goiter. Neurologic assessment and any abnormal examination finding. Evaluate estrogen and androgen effect. Androgen effect like masculinization, hirsutism, and so on. What about the investigation? We have imaging and the lab test. Imaging, very important to do bone age radiography, and you will find it advanced. Do adrenal imaging to know if there is adrenal tumor pelvic ultrasonography for ovarian tumor, MRI for brain, because I wanted to search for any hemorrhage tumor or any other lesion. Lab tests include measuring of serum estradiol, testosterone, FSH, and LH. Of course, if there is precocious puberty, estradiol will be high, more than 10 picogram per milli. FSH and LH will be in the range of normal adult. In case of heterosexual precocious puberty, testosterone will be high. Gonadotrophic releasing hormone analog stimulation test, giving the patient gonadotrophic releasing hormone, then elevated LH means central precocious puberty, suppressed LH but elevated sex steroid means peripheral precocious puberty. What is the management of precocious puberty? First, indications for referral to pediatric endocrinologist. It's very important. If there is rapid pubertal progression, any pubertal change before the age of 6 years, pubertal changes associated with headache, vision changes, new onset seizures, confirmed central or peripheral precocious puberty, non-predisposing condition like previous irradiation, brain tumor, neurofibromatosis, or infiltrating disease. What is the aim of the treatment? The first and very important, to prevent emotional problem and psychological problems. Also, to prevent premature closure of the epiphysis, to help the linear growth of the girl. Because if premature closure of the epiphysis happen, the girl will be short. Also, to prevent pregnancy in a girl. Also, arrest premature sexual maturation until the normal pubertal age, and also to preserve her future fertility. What about the treatment lines? Maybe surgical one or medical one. Surgical, like treatment of the cause, like in cases of ovarian tumor, like granulosa cell tumor or circular cell tumor. I do laparotomy and excision of the tumor. Also, management of brain tumor and other brain lesions. Medical treatment in cases of central precocious puberty. The best medical treatment is GnRH analog therapy like leuprolide 7.5 milligram given intramuscular monthly, or another dose 11.25 up to 30 milligram intramuscular every 3 months, or to give it like subdermal implant 50 milligram, what is called hysterly, and it continue to act for 1 year. The child continued to receive the medication until reach the normal age of puberty. Also, I should mention in medical treatment in case of Macon-Albright syndrome, I may need letrozole 2.5 milligram per day to prevent production of estrogen from peripheral areas in different areas. Okay, let us go to the another group, which is delayed puberty, which can be defined as failure of development of secondary sex character by the age of 13, or haven't had menarche by the age of 15, which is called also primary amenorrhea. Why it happens? Okay, we can divide the etiology into three categories. Either normogonadotrophic normogonadism, both gonads and the hypothalamo-pituitary axis is normal, or hypergonadotropic hypogonadism, or hypogonadotropic hypogonadism. What about normogonadotropic normogonadism? The hypothalamo-pituitary ovarian axis is normal, but the problem here is anatomic abnormality of the genital tract or end organ defect, like Mayer-Rokitansky-Kester-Hauser syndrome, in which there is Mullerian agenesis, absent uterus, absent cervix, vagina, and so on. Or it may be due to obstruction like imperforate hymen or transverse vaginal septum causing cryptomenorrhea. The other big categories, hypergonadotropic hypogonadism, the ovaries are not functioning. That's why we call that hypogonadism. The ovaries are not functioning and are unable to respond to gonadotropic hormone. As a result, gonadotropin hormone level is high. Like which cases? So if we measure the FSH, LH, we will find it high, very high. Why? Because the ovaries cannot respond to FSH. So there is more production of FSH and LH, and the more stimulation of the hypothalamus pituitary axis. What are the causes? Turner syndrome, which is 45X syndrome, or pure gonadal dysgenesis, like 46XX or 46XY phenotypic females who has streaks gonads. Early gonadal failure, primary ovarian failure, may occur due to radiation therapy or chemotherapy or any other factor. Let us go to the third group, which is hypogonadotropic hypogonadism. The ovaries is normal. However, signals from the hypothalamus is abnormal. So the problem here in the hypothalamus-pituitary axis, and the ovaries is normal. The causes may be constitutional, this is the commonest one, psychological stress and anorexia, isolated gonadotropin deficiency, as in Kalman syndrome, Loris-Mondidel syndrome, multiple pituitary hormone deficiencies, neoplasm of the hypothalamus and pituitary, radiation of the CNS, infiltrative diseases like sarcoidosis, Cushing syndrome, hypothyroidism, malabsorption syndrome, and the other chronic debilitating diseases. What about the diagnosis of delayed puberty? Through history, examination, and investigation. Through history, first, we should know the pubertal milestones of the mother and sister, disorders of the pregnancy, labor, delivery, birth weight, and birth trauma. What about the nutrition of the girl? Poor linear growth, systemic medical disease, absent or not, neurogenic symptoms, if any of them, family history of anosmia or hyposmia, and relatives like Kalman syndrome, and the delay in age of onset of puberty. This is very important about family history. In examination, we will measure the weight and the height and the body mass index, upper and the lower segment ratio, also another ratio, arm span, and the height ratio. Again, evaluation of the Tanner staging and know which stage the girl belonged to. Also search for any signs of Turner syndrome, exclude genital malformation during examination, neurologic examination for visual fields, fundus examination, and sense of smell. What are the investigation needed? I measure the serum FSH, LH, prolactin, and the TSH. Is very important. Radiologic by doing X-ray and doing the bone age and skull X-ray and MRI also for brain tumor and the other brain lesions. Pelvic ultrasound also to know about the ovaries, any problem, their absent ovaries or streaks gonad. Karyotyping is important also, as in cases of Turner syndrome, 45X, or any other anomalies. This is a picture of Turner syndrome, as you see, delayed puberty, lack of secondary sex character, and the facial changes and the foot changes. What about the management? Treatment of the primary cause is very important, like Altraxin in case of hypothyroidism, growth hormone for isolated growth hormone deficiency, treatment of chronic illness as malabsorption syndrome or any other chronic debilitating disease. In constitutional delay, conservative management with observation over 6 months is preferred by many doctors, and at the same moment, reassurance that development will occur soon. Sometimes you are in need for hormone therapy. You can start with low doses of estrogen, like conjugated estrogen as Primarine 0.3 milligram per day, oral, or by using skin patches. Some prefer skin patches over the oral estrogen. The aim of induction of puberty in girls with hypogonadism to achieve timely secondary sex characteristics, including breast and uterine development. This leads to menses, generation of pubertal growth spurt, and finally acquisition of peak bone mass. So, what about the common condition requiring sex steroid replacement? Gonadal dysgenesis, as in Turner syndrome, and the other gonadal dysgenesis 46XX and 46XY, constitutional delay of puberty in some cases, premature ovarian insufficiency, surgical hypogonadism, hypopituitarism, hypogonadotropic hypogonadism, hypothalamic amenorrhea, and disorder of sexual development. Lastly, the current opinion favors induction of puberty with transdermal estradiol patches starting at doses of 6.25 microgram in the younger age group and 12.5 microgram in older age group. This treatment should only be initiated with input from a pediatric endocrinologist. Yes, of course, you should consult pediatric endocrinologist in these cases. And usually when you give estrogen to as a treatment of delayed puberty and for induction of puberty, you should start with low dose estrogen without progesterone up to 2 years, then you may add progesterone. Also, another important item is to start with low dose estrogen first, like 0.63 milligram, as in case of Primarine drug oral, then shift it to 0.625 milligram every day oral, then later on increase the dose up to 1.2 milligram oral per day. So this is for oral use. Also for batch, you can start with 6 of the batch, then fourth of the batch, then half of the batch, then one complete batch. Each dose continue for 6 months at least, then increase the dose gradually. After 2 years, you can add progesterone to cause withdrawal bleeding and simulating the adult normal physiologic menstruation. This is the end of my lecture. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine in Sura University.